Okay, so welcome to the ERA EDTA's CKJ Journal Club. It's an e-seminar which takes place every Thursday at the end of the month at 17:30, 5:30 in the afternoon Central European time, which is 4:30 in the afternoon UK time. It's an e-seminar which picks out a topic from a recent CKJ original research article or key review article, and the authors will introduce their work, and there'll be at least one expert member on a panel. It will be moderated by the CKJ Editor-in-Chief, Professor Alberto Ortiz, or myself, Will Herrington. I'm an Oxford-based nephrologist, epidemiologist and trialist, and editor at CKJ. The discussion will last up to an hour. It'll be fairly informal. We hope it will be lively. It's live across social media. If you have questions, please use the Q&A box and we'll try and address as many of them as we can as we go, and we'll even address those that we can't afterwards. It will be recorded, so you'll be able to watch this on various video platforms afterwards, and keep an eye out on the social media for the various links. And this week is a special e-seminar because it's the first, and we hope some of our excitement in running this e-seminar rubs off onto you as well. And the topic this week is one of an exploratory study of intradialytic cycling and cardiac stenting. Cycling has been enjoying a boom in COVID-19 lockdown period, particularly with stationary bikes in virtual worlds. So today's topic is topical within the realms of what we're all facing. And I'm really pleased to have with us Dr. Scott McGuire, who's a research fellow at the Faculty of Research Centre for Sport and Exercise and Life Science at the University of Coventry, who's first author of today's original research paper. Welcome, Scott. Our expert panelist is, as Scott has just explained to us, is a bit of his inspiration is James Burton, who's also from the Midlands in the UK. He's an honorary consultant nephrologist who leads an exercise rehabilitation and dialysis program, but he's also professor of renal medicine at the University of Leicester, has a key interest in cardiovascular disease, and is principal investigator of the Cycle HD trial. James, your Twitter account exposes you as a Star Wars geek as well. So does your wall. So thank you both for joining us. Scott, you're a physiologist, and you describe yourself as working both in elite sport as well as healthcare. I just wondered, before you presented your research, whether or not you might just tell us if you're a keen cyclist or not, and also how you got involved working in end-stage renal disease patients.
So thanks for that introduction, Will. So in regards to cycling, I'm not as big of a cyclist, I'm more of a runner. However, it is something I would, take up. I'm very interested in kind of triathlons and things like that, so I would like to do it. But again, I prefer the running. In terms of why I got into working with end-stage renal disease, my background was predominantly in sport and exercise science, working at Everton Football Club as a general sports scientist for 2 years. And then I moved on to as a sports nutritionist after my master's degree at Manchester United. I did this for close to 4 years in Premier League football. However, I really wanted to look into clinical work. It was something that was always interesting me, and working alongside the doctor at the club, it was just something that I really wanted to get my teeth into. So I looked online, found a PhD looking into end-stage renal disease, and within my remit of exercise physiology as well. So it fitted the picture perfectly to get exposed to clinical work, but within my remit, so to speak. Once I got into it, absolutely loved it. This population, the disease itself, obviously many people will be aware, has widespread debilitating effects on the patient, and to do a PhD that could potentially help those people made kind of all reason for me to pursue a PhD in that, because I was actually set up to do a PhD with Manchester United at the time, but it didn't really tick the boxes for me in terms of real impact, and that's why I actually pursued the kind of clinical route. The fact that it was an end-stage renal disease was mainly due to the opportunity, but now I'm in it. It's undoubtedly an area of research that I want to just keep expanding on. Yeah, so that's the reason I got into it.
Thank you, Scott. So, well, it's great that the kidney patients have your expertise and you've turned your back on Premiership football. Please, would you like to show us your slides and tell us all about the study?
Yes, I'd love to. I'll just quickly share screen. So is that coming up on your screens there, Will, just before I begin?
Yes, we can see it.
Yeah, all good? All right, then. Excellent. All right, I'd like to thank the ERA-EDTA for the invitation to speak today, and obviously everyone in attendance for this. So this is our study looking at cardiac stunning during hemodialysis and the therapeutic effect of intradialytic exercise. So in the interest of time, I'm just going to get started straight away. So end-stage renal disease is linked with a whole host of negative comorbidities that are severely limiting to quality of life and life expectancy for these patients. To counteract this metabolic homeostasis that is lost with end-stage renal disease, a lot of patients undergo hemodialysis. However, hemodialysis in itself can have detrimental effects on cardiac tissue, cerebral, and gastrointestinal. And one of the panelists today, James Burton, has wrote a lot on the detrimental effects of hemodialysis in all of these tissues. But today, specifically, I'm going to look at the heart, and this was the focus of this study. So James Burton actually demonstrates nicely here that ejection fraction does indeed decrease with the HD vintage. So the longer a patient is on hemodialysis, we have this decrease in ejection fraction. So over the course of 12 months here, patients experiencing regional wall motion abnormalities, which I'm going to touch on in subsequent slides, had this decreased ejection fraction, which is indicative of systolic function and is one of the criteria for heart failure. So this is going the wrong way, really, if we look at it in terms of a heart failure perspective. Why does this happen? Well, one of the main roles of hemodialysis is to take off the excess fluid that accumulates in the intradialytic phase. And patients can lose almost 1 to 3 liters over the course of a 3 to 5 hour treatment. So why is this problematic? Well, if we look at the heart itself, decreasing plasma volume can negatively impair preload, and this in turn can negatively affect contractility, subsequent cardiac output, and coronary perfusion. So this mechanism explains why we have ischemic injury to these tissues and ultimately dysfunction as a result of hemodialysis. So the more aggressive the ultrafiltration volume or rate, the worsening of this problem that we do indeed see. And Buchanan really nicely demonstrates this using MRI, showing that the mechanism I just described in that stroke volume does indeed decrease. And interestingly, we don't actually see a compensatory response in terms of heart rate to offset this decline in cardiac output. And this also persists if we are to just look at the bottom there, the 50 minutes post hemodialysis. So this is a great problem that occurs with hemodialysis, and this is nicely evidenced with MRI here. And in the same study, Buchanan also demonstrated that myocardial perfusion does indeed decrease as a result of this as well. So here demonstrating that myocardial perfusion decreased in both HTF and HD dialysis treatments. So again, demonstrating that myocardial perfusion is indeed decreasing. And this corresponds with an increase in regional wall motion abnormalities. Now, these are indicative of areas of the myocardium that are becoming dysfunctional as a result of hypoxia or ischemia, subsequently leading to the hypoxia. And as a result, we have dysfunction in those segments. And I would like to draw your attention in this slide that if you look at the 70 minutes post period here, we see that these regional wall motion abnormalities persist even after hemodialysis. So if we think of one of the common complications of dialysis or reported negative effects of treatment, in that there's a lot of post-dialytic fatigue in close to 50% of hemodialysis treatments, it would clearly show that a dysfunctional myocardium may in fact be contributing to this, and there has been studies that have demonstrated that post-dialytic fatigue is indeed linked to the occurrence of these regional wall motion abnormalities. Now, this will greatly impair quality of life, but more worryingly, again, nicely demonstrated by James Burton, one of the panelists today, that regional wall motion abnormalities are also linked to decreased survival. So in this study demonstrating that patients experiencing these regional wall motion abnormalities have a decreased survival in comparison to those who did not. And it's worth also mentioning that the vast majority of MRI, transthoracic echocardiogram studies demonstrate that the majority of patients experience these regional wall motion abnormalities more so than obviously the patients who do not. So this is a widespread problem. And just to give you an example from this study that I'm going to talk about today, all of our patients experience these regional wall motion abnormalities. So just really highlighting the extent of this problem. So where does exercise come into this, and where could it be potentially beneficial? Well, this was an article that we got published in the second year of my PhD, talking about that mechanism that I've just described in that. So if we look at the center here, showing that plasma volume and fluid reuptake decreasing as a result of that ultrafiltration that I mentioned, subsequently decreasing venous return to the heart itself, decreasing left ventricular preload, subsequently contractility, decreasing stroke volume, cardiac output. This in turn leading to decreases in mean arterial pressure or systolic blood pressure, which I'm sure many of you are aware is a common complication of hemodialysis. Again, is intradialytic hypotension. And this is one of the mechanisms for why. In turn, leading to a decrease in coronary perfusion, and then a subsequent increase in regional wall motion abnormalities. And just also worth mentioning at this point that these regional wall motion abnormalities indicate that dysfunction of the myocardium, and this may in fact perpetuate further decreases in cardiac output due to that loss in function. And this cycle can continue for until something obviously happens in regards to mortality, that is. But why would exercise have any potential benefit here? Well, exercise had the advantage of potentially influencing all elements of this negative cascade of events that I've described. So there has been small studies demonstrating improved vascular refilling, so increased interstitial fluid into the vasculature via osmotic gradients, and ultimately leading to an increase in plasma volume. There is the advantage of the skeletal muscle pump, so the contraction of different muscle groups, such as the gastrocnemius, when we run and walk, can aid that venous return. This increasing that left ventricular preload and potentially offsetting the decrease in stroke volume, cardiac output, and subsequently the regional wall motion abnormalities. So this was the rationale, this was the reasons that we were thinking that intradialytic exercise or exercise during dialysis may actually, in fact, decrease the occurrence of these regional wall motion abnormalities. And here we have one of our patients undergoing intradialytic exercise. So on the right, we have the cycle ergometer, which is actually the bike that we would attach at the end of the dialysis chair. On the left here, we have the echocardiogram. Transthoracic echo was actually how we looked at those regional wall motion abnormalities that I've mentioned. We also looked at other different cardiac parameters as well. However, I'm just going to focus in on strain analysis today due to it being our primary outcome. But if you do read the paper, you'll find that there was we looked at cardiac output, ejection fraction, a few other different things as well. We also looked at gas exchange, and one of the reason for this was twofold. We wanted to objectively quantify the exercise intensity that these patients exercised at. And the reason this is so important is if we were to use an example of a drug, we wouldn't compare an intervention whereby we prescribe multiple different doses of a drug and ultimately measure the response, because the response is mediated likely by the differences in drug dose. However, in exercise physiology studies, you do find a lot of the time that the exercise is very subjectively prescribed. And the real risk is here that you're not comparing like for like. So we really want to do a well-controlled objective measure here by using a cardiopulmonary exercise test prior to this to prescribe the intradialytic exercise phase. And we got these patients to exercise at 90% of their anaerobic threshold based on the preliminary cardiopulmonary exercise test. So this is why we wanted to look at gas exchange as well to see if they were achieving that intensity that we prescribed. The other reason and other rationale for this was we know very little about the kind of metabolic or O2, CO2 kinetics that occur during a phase of hemodialysis. There is some studies out there that do have elaborated on this, but it's not widely discussed, and we wanted to add further to this, especially in the context of intradialytic exercise as well. The patients exercise for 30 minutes after 1 hour of hemodialysis at 90% of their anaerobic threshold. So quite a high intensity in that regard, but below the anaerobic threshold for each patient should suggest that these patients are able to maintain that exercise intensity for this level of duration, if that makes sense. So the patients cycle for around 30 minutes for the reasons that this is what is widely prescribed in terms of intradialytic exercise, and we really wanted to understand and investigate what the common prescription of intradialytic exercise to potentially look at the benefits in terms of cardiac stunning, but also the potential detrimental sides. Could, by stressing the heart, we make regional wall motion abnormalities worse? We really didn't notice at the time, and this was another reason why we needed to investigate this if intradialytic exercise was going to be more widely adopted. And finally, we did the same measures that we did during intradialytic exercise during a standard hemodialysis treatment as well. So the patients acted as their own controls, if that makes sense. And I'm just going to quickly introduce you to strain imaging. So I have put the equation up in the corner there, but it is the length during systole, or the myocardial length during systole, minus the myocardial length during diastole, divided by that myocardial length during diastole. When we times it by 100 to get to a percent myocardial strain deformation. So this is why myocardial or longitudinal strain, that is a negative value. I'll not go into more depth than that, but if you just bear that in mind, it's a deformation. So it's a change from diastole to systole. So we should see a decrease in the length of these different segments of the myocardium. And how we measure these different sections of the myocardium is we place the probe at the apex of the heart, and we can get these two-dimensional images. For those who have never seen transthoracic echocardiogram, we can do these different cuts and get an overall indicator of left ventricular function. And we focus predominantly on the left ventricle for the reasons that it's such an important variable when it comes to systemic circulation. But what this allows us to do is quantify specific segments of the myocardium, and ultimately we can look at where changes in the myocardium are occurring as a result of the dialysis. And we can actually produce these, which are called bullseye plots, and this allows us to look at those individual segments that I mentioned. So just to give you an example, the bullseye itself in the center there is actually the apex of the heart. So we can actually see it split up the myocardium into specific segments and quantify that change. This is actually one of our patients. This was prior to hemodialysis, and this we can average out all of these segments to get something called GLS, or global longitudinal strain. And in this case, it was minus 10.9. And this is a standard GLS that we found in a lot of our patients. Now, bearing in mind in a healthy individual like ourselves, we would expect this to be around a -20 mark. So this is already indicative of a lot of cardiomyopathy or loss in function of the myocardium as a result of the disease itself, of course, but then equally from these repeated bouts of ischemia that happen with hemodialysis. So it's just worth highlighting that. And here we have some images of the myocardium that I mentioned. So looking on the top left of each one of these sections, this is an apical 4-chamber view, 2-chamber view, and then a 3-chamber view. So you can actually see the aortic valve creeping into the image there. And this allows us to quantify that global left ventricular function that I mentioned. Now, this is baseline, so prior to the hemodialysis. So this is in one of our patients again. And if we were to then look at the right, at the bottom corner, I hope you can see that clearly. This is these blue areas that are arising. This is indicative of dyskinesia, or areas of the myocardium that aren't contracting correctly as a result of that ischemia that I mentioned. And this is the typical response that Buchanan and James and multiple of other studies have clearly identified with hemodialysis. So this is a really widespread problem, and there's now plenty of evidence that this is indeed due to the hemodynamic stress that hemodialysis puts on the body, ultimately relating to this dysfunction. When we look at global longitudinal strain, so if you recall, that was the averaging of the bullseye plot that I mentioned, we see that it does indeed decrease significantly from baseline, like many other studies have demonstrated. However, we didn't actually find any differences or any changes between the intradialytic phase, which was constant load exercise on hemodialysis, our blue line here, in comparison to HD alone. When we looked at cardiac stunning specifically, so we looked at these stun segments, and it's worth defining what these stun segments are. This is defined as a 20% decrease in function in those individual segments that I mentioned. So we can total up or quantify the number of these regional wall motion abnormality segments, and this is what this is, and then we get an average. So here we find that over the course of hemodialysis, we do indeed see that regional wall motion abnormalities increase over the course of hemodialysis. And this corresponds, similarly to all the previous studies, with that decrease in cardiac output as well. However, when we put exercise in here, what we did find was 1 hour after the bout of intradialytic exercise, we actually found a significant decrease in the number of regional wall motion abnormalities as a result of intradialytic exercise. Intriguingly, cardiac output, though, didn't show any differences at these time points. Almost identical response in terms of cardiac output. So we found that, of course, the regional wall motion abnormalities do indeed decrease, which was a major finding for us, but it didn't seem to be mediated by the mechanism that I described earlier. I must stress at this point as well, though, we didn't measure myocardial perfusion, so we can't completely rule it out. But based on this information and based on the previous mechanisms I've described, cardiac output didn't appear to be relating to this decrease. Also, we would have likely expected this acute change in the immediate post period, but we didn't. We've seen it that 1 hour post-exercise phase. So quite intriguing results, I hope you agree. And this is just the same data, but in bullseye format. So on the right here, if you look at the 1 hour post-exercise phase and before, it is worth mentioning, the patients had a very similar cardiac function. If you look at just the color changes alone, so the red being greater strain deformation than the white areas, which are actually hypokinesia. If we look on the right where the hour exercise or the post-exercise phase where we've seen the significant difference, I hope you can agree that with hemodialysis alone, you can see that there's a lot more dysfunction there in comparison to the exercise component. And that's where we've seen the significant difference. And finally, it's really worth pointing out that we're not the only ones to demonstrate this response. These two studies So this is, I really hope they're watching today, because you know, it's a very intriguing finding that they also got, which was a group in Canada. So Penny et al. Also demonstrated a very similar response, that there was a significant difference in regional wall motion abnormality occurrence at the peak. They termed theirs peak stress, but this was the post-exercise phase. So these are completely independent trials, unaware of each other's existence and what we were actually investigating, that came up with almost identical responses in a lot of regard. So quite reassuring that the physiology seems to be there, and we seem to have found a very similar response. So quite reassuring in that regard. And the final point I really want to make is that it's these mechanisms that might actually explain why, with long-term intradialytic exercise, we do see improvements in ejection fraction and decreases in right ventricular size and decreased bouts of intradialytic hypotension. With the Cycle HD trial that James Burton is currently undergoing, it would, it'd be very intriguing to see if these of intradialytic exercise does indeed relate to better cardioprotection. But there is plenty indicators to say that it should. Maybe this is the mechanism in which why we see improved function. So to summarize, intradialytic exercise significantly reduced regional wall motion abnormalities 1 hour post-exercise in comparison to HD. It's one of the first studies to demonstrate this response, and alongside Penny's work, I must admit, and the first to objectively characterize exercise dosage in non-trained patients with a range of comorbidities. There's definitely evidence here for a large RCT trial in that regard, and understanding the molecular mechanisms that potentially underpin this response is also definitely a valid line of inquiry. Thank you all for listening. I hope it was intriguing to you.
Thank you very much, Scott. I really enjoyed that. I'll confess to being quite a keen cyclist, and I've got one question for you before I ask James his thoughts. Could you just give me some idea of the intensity of this cycling? I saw 90% of the VO2 anaerobic threshold, and that seems to be something that sounds very high for a Zwifter. I wasn't expecting to see a patient wearing trousers and a jumper. So given an amateur cyclist might push 150, 200 watts for half an hour, and Chris Froome or someone in the Alps as a top international would push 400 plus, what types of level of work and intensity are the patients on dialysis hitting?
So the average wattage that we actually had these patients working at wasn't anywhere close to those kind of intensities, but it was around 35 watts on average. Again, this is relative though, so this was the wattage that was prescribed based on their output during a cardiopulmonary exercise test. So it was 90% of their anaerobic threshold, and that was then obviously prescribed based on that rationale. Again, this was an intensity that theoretically, if we were all to exercise at 90% of our own anaerobic threshold, we should be able to maintain due to us being able to work aerobically. We kind of picked the upper threshold for the reasons that if this threshold was indeed safe and didn't worsen regional motion abnormalities, then anything below that we would expect to be safe in a lot of regards. So that was really the rationale, but it should also be an intensity that patients could maintain because they should be working aerobically. Of course, it's not as straightforward as that with hemodialysis, and I can elaborate on that a little bit further at some point, but again, that was the rationale. So around 35 watts to answer your question.
Okay, and so I want to come back to safety and sort of implementation type questions a little bit later.
Yeah.
I wanted to ask James what he thought about the study and Scott's conclusions. Is there data to support this from elsewhere? And maybe we could start talking next about mechanisms of how this is working, as that seems to be clear uncertainty. So James, your thoughts?
Yeah, so Scott, that was really great. It was really nice to see that kind of that cardiovascular journey of what it's like to have a session on hemodialysis. Certainly acutely, you talked a little bit about the sort of long-term consequences of dialysis on cardiac performance and the development of systolic dysfunction, but it was really nice to see potentially the acute effects of dialysis on the heart. So I remember when I was pitching a cycling study to the NIHR, and it was very much kind of like exactly as you've shown. So over a 4-hour period of dialysis, you showed very nicely that cardiac output goes down and myocardial perfusion goes down, and regional wall motion abnormalities become more prevalent over time. And I remember them just saying to me, what on earth are you doing putting these people on a bike? You know, we wouldn't do you wouldn't give them stress adenosine. You wouldn't get them doing a treadmill test at that. And yet here we are, we're putting them on a bike. I mean, it almost sounds, we all know exercise is good for people. Why on earth are we doing it now? I mean, it sounds mad, doesn't it? But
entirely.
So what would your comment be on that? I mean, I can guess what it would be, but what do you think about that?
It's quite interesting, because if you look at, because I've played with this notion in regards to just exercise in itself. Exercise elicits very similar to responses as what pathology does in most diseases. And what I mean by that is you do increase free radical production. You do elicit ischemia, hypoxia acutely. But it's I suppose the question is, when does this become pathological? Disease is almost a chronic hypoxia or a chronic ischemia that leads to eventual derangement in the physiology. But acute bouts of stress is and can be protective, and that's what exercise really does. So it's like everything in physiology and science. It's not as simple as saying one is good and one is bad. It's probably looking at it from that perspective. So this acute bout of potential where you're causing a further hypoxia or ischemia may in fact relate to some protection. And there is mechanisms, and there is a lot out there in terms of preconditioning effects, expression of different microRNAs, heat shock protein expression. These mechanisms are and have been found, not necessarily in end-stage renal disease populations, but can be cardioprotective and almost make cells more resistant to hypoxia. And I personally think this is what we're seeing here. And I can't take total credit for that. Again, I must highlight Penny's work, who does also elaborate on a preconditioning effect. Yeah, so that would be my answer.
Well, I think it'd be nice to debate that whole thing about preconditioning a little bit more. I suppose, my sense would be, so all of the people that we've recruited into exercise on dialysis trials, whether that is the Cycle HD trial or the pedal trial, the majority of them, it is fair to say, are not coming from a baseline where they are active people who are saying, oh yeah, I'm going to carry on my exercise program here on the dialysis unit. They are very, very deconditioned people who are probably very sedentary. And I think when you're coming from that position of being deconditioned in the first place, when you start, exercise is actually, it can be quite pro-inflammatory. So what do you think about that kind of, that first introduction to someone to exercise, who's very deconditioned and used to being quite sedentary?
Well, if we just look at people who are more sedentary, you can actually put the point across that the adaptations are more rapid and more beneficial in a lot of regards as well. So if you have someone who's very well conditioned, the margins for improvement are so slight. However, those who are severely deconditioned, the improvements can be vast. So if patients are to give this a go for a long enough period, you would expect them to really feel the benefits. And I suppose that's almost an advantage in a lot of regards to prescription of exercise in that regard. Depending on the exercise intensity, like you've elaborated to, you do get changes in inflammation. But again, some of these mechanisms are normal in a lot of regards. So me and you, if we were to just exercise, we would also promote some of these responses. They're not necessarily detrimental. They're due to remodeling or changing. or physiological adaptation to the stress, which, if anything, is an indicator that you're doing it right. But I totally get the point that if you're very deconditioned and you have a severely limiting condition as well, this would be a hard concept to understand and get your head around. But again, it is a normal response. An example being that IL-6 is actually increased with exercise, which is typically a pro-inflammatory cytokine that we would normally associate with disease, but it has lots of applications in release of glucose, et cetera, et cetera. So it's just how we approach it with exercise. But the benefits seem, never ending really. And again, this is another example of it.
I know there's quite a few questions, but I'm going to hog you for one more myself, Scott, because I feel as if I've got that privilege. So we talked about exercise intensity, and in the Cycle HD trial, the average, power output was actually only 18 watts. Now, we didn't do cardiopulmonary exercise testing to set a prescription for exercise. We did it on a rating of perceived exertion, so that patients were exercising to what they thought was moderately hard or hard. And we can debate the ins and outs of that. But nevertheless, their perceived work was that they were working pretty hard, and yet their actual work was very low. And you've talked about 2 studies that saw that abrogation of cardiac stunning with exercise. And actually, over the long term, what we saw was a reduction in LV mass by more than 10 grams after taking part in an exercise program for 6 months. And I guess my sort of question, and you have alluded to it a little bit, is if the normal adaptation in an athlete who is exercising would actually be that their left ventricular mass would increase, because that's what happens when you work a muscle. And so actually with people on dialysis who are deconditioned and they've got LVH already, probably 90% of the time, how is doing that little work, how do you think, what's the mechanism behind the fact that they regress their LV mass in that circumstance, when we know LV mass is a predictor of outcomes for people in this group?
Yeah, it's a really interesting question. I do recall you presenting some of this data, I think, in the Kidney Week, and it is an intriguing response. You do see this reduction in left ventricular mass in a lot of pathological conditions. However, the hypertrophy that you typically see, let's say, for example, after an MI, that pathological remodeling is it predisposes the patient obviously to increased risk for the fact that the heart is hypertrophying without necessarily the angiogenesis to support the blood flow to that tissue. So by reducing the mass, it's actually cardioprotective in the sense that you can perfuse that tissue better. Whereas in just again, I can only use really the MI example, but tissue surrounding to compensate for that infarcted area has to obviously hypertrophy to maintain the cardiac output, but this then predisposes the patient to greater ischemic risk due to the lack of the angiogenesis that you would typically see. However, when we exercise, we get that increase in vascular endothelial growth factor, and ultimately that in itself becomes cardioprotective. So again, it is an interesting point, but I suppose the other side of it is, it depends on what the benefits are. If this is, let's say, a long-term benefit where blood pressure is decreasing, you're decreasing LDL cholesterol, etc., and endothelial function is improving, that in the long term may be actually decreasing the constant preload on the heart, and as a result, it doesn't necessarily need to hypertrophy. So it depends on which element or which benefit of the exercise is really corresponding to the change in ventricular function. So I hope that kind of answers your question, but I think it's a complicated one in terms of, there's multiple mechanisms there. But
I mean, I completely agree with you, because the whole point is that exercise actually has benefits in many different areas. It doesn't matter whether it's blood pressure or dyslipidemia. or a direct effect on hemodynamics, or whether there's some crosstalk, like you said, with microRNAs between skeletal muscle and cardiac muscle that we don't understand yet.
Yeah, so it's a fascinating point around, physiological hypertrophy and that of pathological, and the adaptations there should be similar, but they're not, are they? And again, it's fascinating how many.
But it does all fit with all of that observational data that, despite what we think about may be the detrimental effects of it acutely during dialysis, all of the observational data about exercise during that dialysis period is that it's associated with positive outcomes for patients. I mean, there's just no doubt about that.
There's a question or 19 in the Q&A section, and so we can't answer them all, but we will try and answer some offline afterwards for those that haven't been addressed. But there are a few questions which I think are worth trying to talk about now, and one of them is talk about ultrafiltration. That's a question from Ken Willand. So there's a specific question from Ken about what the average ultrafiltration volume was. Can you remind us what you saw in the paper?
I don't want to lie. Let me just quickly check. I believe I have got it on here.
Whilst you're checking that, I'm going to ask James a question about, because Scott circled a paper which showed that there was no decreased risk. In fact, there may have been a decreased risk of intradialytic hypotension with these types of exercise, which to me seems completely counterintuitive, given the exercise will push blood to the skin, increase salt excretion under the skin, and I thought it would sound like a recipe for intradialytic hypotension. So when you do this exercise in your trials, do you stop the ultrafiltration during that period? And if you don't, why do these patients not get intradialytic hypotension?
That's a great question, Will, actually. And one of the pilot pieces of work that we did before we started the Cycle HD trial, because we were really worried about that, actually, because the narrative is that this intuitively doesn't sound like a great idea. Exercising someone on an extracorporeal circuit does not sound like a great idea. And the truth is that it does cause those usual physiological fluctuations in blood pressure. So while you're exercising, your blood pressure goes up a bit, and when you stop in that period afterwards, your blood pressure can dip down a little bit. Not really dipping down any much more than you would have started at baseline, but it's enough to be worried about. And so we thought very carefully about how we were going to follow that, because we didn't want people to be worried about exercising on dialysis. The truth is, we didn't go hunting for it, but nobody actually complained of any instability during dialysis. I know that doesn't sound great, because we know that intradialytic hypotension can be asymptomatic. We didn't do any more regular monitoring during the Cycle HD trial than you would do normally, but we didn't see anybody who had any symptoms, and we didn't see anybody who dropped their blood pressure at the times that it would normally be taken on dialysis. And actually, there's some evidence that by cycling during dialysis, you improve your clearances, that you improve your KT over V. So there's definitely some benefits in venous return, which may help to stabilize dialysis, as Scott was saying. So intuitively, you're right. It sounds like it wouldn't be a good idea, but there isn't anything to suggest that it causes those in real time.
Again, I would just kind of highlight that when we did go into this, we didn't know what the benefits were. We proposed a mechanism of what may be indeed beneficial due to the mechanisms that I described in the presentation. But equally, like James has also alluded to, there is inherent potential risks there, but they didn't seem to be warranted. And it's not just now my own study, there's multiple studies that have demonstrated that it doesn't appear to be causing any worse situation, but it more so improving things. And in terms of if there was another mechanism that potentially is beneficial, if we think of the fact that if we increase adrenaline, we do actually redivert blood flow to cardiac tissue and cerebral. So it's not necessarily detrimental in as many regards as I think as we're going down. There's enough rationale for why it may also be beneficial, and again, that kind of came up in the results that we had. I'm just going to quickly just point out that the filtration rates that we were having was around 470 milliliters per hour. Just answer the question that you had earlier on.
Whilst you've got that table up there, Scott, we've got some other questions. I think people are, well, I was impressed by 35 watts for sitting in trousers and a jumper. Some other people who have asked, Claire Wheat has asked about the average age of the cohort. She particularly gets her patients struggle to do submaximal exercise, mostly because of age, but also from motivation. Mm-hmm. And so how old are the patients? And then the second question related to that is there was a question about whether or not special groups like children on dialysis might be something you should consider this for. So maybe you could address those, the question of age.
Well, in regards to age, the average age was 59, but we did have patients, up to 70-year-old in that regard. So, and we also bear in mind, none of these patients were under any intradialytic exercise program. They were completely novices to this intervention, so to speak, and they weren't regularly exercising. And we did have severely deconditioned patients in that regard. Even just looking at ejection fraction, our average ejection fraction was around 50%. So they were very well deconditioned, and again, we still demonstrated this benefit in some very severely deconditioned patients. Sorry, you're muted, Will.
And there's another question about, someone has asked about whether or not there's a comparison between intradialytic and extradialytic exercise. I guess one of my thoughts is, did this exercise on the machines get them addicted? Did you track whether or not the patients who were also exercising on the machines changed their physical activity levels between dialysis sessions?
So in answer to that question, sorry, as well, I'll answer the one on the children with dialysis as well. I did miss that. So in regards to the changes in exercise kind of habits that occurred with our patients, yes, we had, I would love to say that 100% of the patients adopted exercise afterwards, but they didn't. But we did have patients actually who now regularly attending our cardiac rehab unit, which is predominantly for phase 3 and phase 4 cardiac rehabilitation, but they are attending intradialytic exercise in that regard, doing similar exercises to what we do for post-MI patients. So we did have some adoption. I still actually get calls in regards to patients from the trial asking about it. Just like every pathology and every patient who adopts these different interventions, they go on and off, and ultimately they'll come back. But this all came from a very small intervention in a lot of regards. So I think if the service is there, people will adopt it, and we've got to look at it from the perspective if one person would benefit from this, then it's worth doing. So I suppose that's the way to approach it. But yes, I would say that it was very positive outcomes. And in regards, in answer to the question around children on dialysis, I don't believe there's a great amount of evidence or looking into intradialytic exercise with children, although I'm not by any means the expert in that area. But again, it would make sense to have the same potential benefits in the youth as but of course their physiology does differ a little bit, so that's another investigation in that regard.
Alberto.
A follow-up question on the extradialytic exercise, which relates to the fact that the benefit was apparent like 1 hour later. So what if the patient does the exercise before dialysis, for example, walking to the dialysis unit? And in this regard, there is a recent paper in CKJ in the August issue by Yasaba et al., Japanese paper, that they looked at how people go to dialysis, and the ones walking to dialysis or cycling to dialysis, even adjusted for age, etc., had like longer survival.
It's a brilliant point, and it's actually I've heard someone else talk about this, and it's a really good point. Ischemic preconditioning has been used as reducing perioperative risk in a lot of regards. So it's a very similar process. You expose the body to this repeated bout of a small acute ischemia or hypoxia, and this relates to, let's say, cardioprotection after that stimulus. Again, if we had this ischemic precondition prior to hemodialysis, then yes, there could be benefits for the entirety of dialysis as opposed to that 1 hour post-exercise phase. So it's a brilliant point, and it's something I would love to do. I suppose the only thing, because it has crossed my mind, would be the patient setup. So, especially on a morning session, some of these patients arriving at 7 o'clock in the morning before their dialysis session, and I couldn't imagine asking them to arrive maybe at 6 o'clock to do 30 minutes of exercise, and then get hooked up onto dialysis. So I think logistically, I don't know how possible that would be. And just going off the general guidelines out there around allowing for that first hour of dialysis to correct for hyperkalemia and some of these other electrolytes that are potentially arrhythmogenic, that's the current consensus. I don't necessarily think there's enough evidence to say that they can't do any exercise during that phase, especially after one bout of hemodialysis, if this was, let's say, midweek. But again, going off the current guidelines that are out there, patients aren't advised to do exercise for that reason. So I don't know if that would be an issue. But again, it's a really good point around the ischemic preconditioning effect.
Can I just make a comment about that on dialysis and outside the dialysis unit provision of exercise? And I think that's a really, really interesting point, because there's an awful lot of evidence to suggest that intradialytic exercise programs might increase step counts overall. If you're looking at steps as a kind of measure of overall physical activity levels, there's also some evidence that it might improve METs. We certainly saw in the cycle trial that those who were doing exercise, their step counts went up a bit. And for those who weren't, over that 6-month period, their daily step count went down a bit. So there is some evidence that it improves your sort of in and out of the dialysis unit physical activity levels. It's also just worth thinking that we know that without supervision, these exercise programs are patchy, to say the least. And the key is what Scott said earlier, is that in patients who are deconditioned, doing something has a really, really positive effect in that first. So doing something is so much better than doing nothing, but doing a bit more than something is less of an incremental improvement in outcomes. And so just doing a little bit where we can supervise people and encourage people on the dialysis unit, I think that is definitely worth exploring on individual units. Doesn't work for everyone, but it does work for those who engage in it.
And I suppose I'll just highlight as well that Penny's work really nicely demonstrated that even lower intensity elicited to this response. So I would say ours was almost the upper threshold for exercise intensity on dialysis. However, using the Borg scale at 10, patients were exercising 3 to 4 in Penny's work, so ultimately showing that you can get these benefits from a lower than moderate really intensity exercise as well.
I think we've got time for just one more question, Scott. And this is a question from Nancy Verdant, who I think the answer relates to what you've just been saying, potentially. Wants to know if patients who did the intradialytic cycling experienced less fatigue post-dialysis. Fatigue's been identified as a key attribute of being on dialysis, which the SONG team have identified from patients and as being something which things need to be relieved, and they're trying to identify instruments to measure it. I don't think the instruments exist, so you may not have had it in your study. But did you measure fatigue, and if not, could you speculate on whether or not you think it might improve fatigue?
We didn't, unfortunately, look at anything along those lines. We did, for the reasons actually James nicely alluded to when I was trying to formulate this study, that cognitive function is indeed impaired with hemodialysis for similar reasons, that you get decreased perfusion of the CNS, and as a result, there is some description of prefrontal atrophy and an impaired cognitive function. So this is a potential real benefit for the same reasons I mentioned before, that when you increase adrenaline, it's almost a 95% redistribution of blood flow to active tissue, specifically cardiac, skeletal, but also the cerebrum itself. So in terms of a mechanism, or in terms of why it may actually be beneficial, yes, I think there's a very strong rationale that you will increase perfusion and actually offset some of the detrimental side effects when it comes to cognitive function on dialysis with intradialytic exercise. So yes, I think the rationale is there, and I think there is potential ways in which we could look at perfusion during dialysis. And there's so many avenues for this now in terms of its application, and the positives, again, that they just seem never ending every time we look at intradialytic exercise, which is reassuring for how cost effective it is, and how easily it could be adopted somewhat.
So I wanted to plug in quickly. There are actually a number of other papers in CKJ looking at physical activity. One of them includes the baseline data from the PEDAL trial. Mm-hmm. So the PEDAL trial is a UK government funded trial, which James alluded to, 335 hemodialysis patients who underwent intradialytic exercise, randomization in this case, which is fantastic. And the assessment was quality of life, mm-hmm. Which might be a surrogate of fatigue, or at least it might contribute. Yeah. And there's a variety of other secondary assessments. Charlene Greenwood, the first author of that, is busy trying to publish the results. So she's promised to come and tell us all about the study, including the results, in a future e-seminar. And I hope, James, you'll join us again and present some Psycho HD results. So I think Scott, yours is the starter, and then we'll have a main course in one when we have some large-scale randomized evidence as well. So really thank you very much to you both, Scott McGuire and James Burton, for all your time. It's been a fantastic discussion. I'm already thinking we should be buying some of these machines for our dialysis units. I eagerly await hearing more details of the PEDAL trial, because it sounds like intradialytic cycling, even though the intensity is low, is high enough exercise to have important benefits for our patients. I hope those that you have been listening will join us again next month. And next month's e-seminar is presenting the ERA EDTA European Renal and Cardiovascular Medicine Working Group's review of potential for IV iron, intravenous iron, to affect cardiovascular disease. So we're going to stay on the subject of cardiovascular disease for at least one more month. And Lucia Del Vecchio from Lecco in Italy, and Patrick Mark from Glasgow will be presenting, and we will discuss more mechanistic and trial evidence next time with expert scrutiny from Dr. Chris Winnells, who's a long-standing expert in renal anemia, actually being one of the first people to administer EPO to humans as part of a trial, and he was a member of the pivotal steering committee. So we look forward to hearing from them and seeing you in a month's time. Thank you.
Well, thanks for that.
Thank you, Scott.
Thanks. Bye. Bye.
Thank you. Bye-bye.